So what are going to be the high-yield questions about device management for chronic heart failure for the IM boards? This is one that definitely is going to appear. So we have a 63-year-old man is evaluated during a follow-up visit for an 8-month history of heart failure. He currently has New York Heart Failure Functional Class 3. His only hospitalizations was at the time of diagnosis. His meds, it looks like he's on Entresto, brand name. He's on a beta blocker. He's on a loop diuretic, and he's on a Mira with spironolactone. On exam, his BP is 110/76, heart rate is 64. Remainder of exam is unremarkable. Labs are within normal limits. ECG demonstrates left bundle branch block. QRS duration is 150 milliseconds, so a wide QRS. And his echo has EF of 25%. Which of the following is the most appropriate treatment? So we could just go through this already to see what we're going to pick. So of course, if I say cardiac resynchronization therapy, that's what we call biventricular pacing. We mentioned that it reduces mortality when in people who have an EF less than 35%, in individuals who are New York heart failure class 2 and 3 for sure, and the QRS complex has got to be widened. That's how we kind of know the ventricles are not synchronized. And when we talk about resynchronization therapy, everyone, you could imagine for those looking at me that, if your left and right ventricle is not synchronized, it could be contracting like this. If you resynchronize them, it kind of does this and helps things out. So that's not a bad idea. I mean, he meets the criteria. And, this is an individual whose EF is less than 35%, and the patient is still New York Heart Failure 3, so he would also qualify for a defibrillator. So I'm really liking A. You almost have to twist my arm not to pick A. So A would be an implantable cardiac defibrillator, which he qualifies for, but he really also qualifies for getting the biventricular pacing, so not a complete answer. Implantable pulmonary artery pressure sensor. Well, his only hospitalization was about 2 years ago or 8 months ago when he first initially diagnosed. He's not having repeated episodes of getting admitted, so I don't think I'll put that in the patient yet. I do want mortality reduction in the patient. And a wearable cardiac defibrillator, well, I think that he definitely needs a defibrillator. I don't think a life vest at this time is going to be what we're talking. He's 8 months out from his last visit. I think that he does need a defibrillator. So I think the combination of answering all the questions is going to be A. Now I'm sticking to it. So yes, for all these things, it shows you need to know the criteria of who qualifies for CRT, who qualifies for ICD, which this patient does. What about this 70-year-old woman is evaluated during a follow-up for heart failure with reduced ejection fraction 7 months ago. She has New York heart failure functional class 3. Her medical therapy consists of brand name is Entresto, a beta blocker, a Mira, and an SGL2 inhibitor, and Lasix on top of that. On exam, normal tensive, heart rate is 60. There's a grade 2 out of 6 holosystolic murmur, heard at the apex, maybe mitral regurg, and a grade 1 out of 6 crescendo, decrescendo systolic murmur, maybe a little AS, aortic stenosis, heard at the base. There is no JVD or peripheral edema. ECG shows sinus rhythm, a left bundle branch block with a QRS complex that's widened once again of 150 milliseconds. An echo has an EF of 35% with mild, moderate mitral regurgitation and mild aortic stenosis, things that we heard on the physical exam. So in this individual, which of the following is the most appropriate treatment? Well, he's already on goal-directed medical therapy, GDM. He has the 4 pillars. We just went over that right here. So he's optimized medically. I see ivabradine once again. His heart rate is 60. I don't think that's going to be a right answer. I see interventions for the valvular heart disease. I don't think we need to put a TAVI transcatheter aortic valve implantation at this time. Plus I would like more information about it, but it's only mild aortic stenosis. I don't think we're at the point where you do a mitral clip, which is a catheter edge-to-edge repair of the mitral valve just yet in these patients. These are things that are always going to be monitored. What I look at in this patient is that, are we on things that reduce mortality? Not to say the others don't, I just think they have to be addressed at this moment. And I do think that having a QRS complex that's widened at 150, having an EF of 35%, having a New York Heart classification of 3. He meets the criteria for cardiac resynchronization therapy, and this is one that is going to be on your board exams. So let's do one more when it talks about device. I do want to spend the remainder of the time to say a few things about stress testing. I promised I'll do that. So this is a 76-year-old man is evaluated for shortness of breath that occurs when walking around the house and when getting dressed. History is significant for ischemic cardiomyopathy and multiple heart failure hospitalizations over the past 6 months. He was treated for colon cancer 2 years ago. There was no evidence of reoccurrence. He has an implantable cardiac defibrillator. Meds are ACE inhibitor, loop diuretic, SGL2 inhibitor, and a MIRA. He took carvedilol and isosorbide dinitrite hydralazine. Both those were discontinued because he was too hypotensive. He was symptomatically hypotensive. On exam, his blood pressure is 92/60, heart rate of 80. Cardiac exam reveals an S3, but no JVD or lower extremity edema. Serum creatinine is elevated, which can't be good. Serum sodium is low at 132, which cannot be good. Hyponatremia is usually a poor prognostic indicator. Echo performed during the last hospitalization had an EF of only 12%, and a patient engaged in a discussion regarding management options. Which of the following is the most reasonable next step in management? Well, I don't think the answer is lower dose beta blocker. He couldn't even tolerate the carvedilol according to the vignette, so I don't think D is right. I don't think he needs to or wants to be hospitalized at this time. I think B and D are gone. It really comes down to, does this patient need a heart transplant, or should we put what we call destination therapy, an LVAD, left ventricular assist device? But, when it comes to transplant, a couple things jump up to my mind is, number one, he has a history of colon cancer. So I'm sure that's going to factor in when it comes to guidelines. And if I'm not sure, of course, I'm always going to ask in the hospital transplant team. And then, I'll throw out age. I know people always say age is only but a number, and you're probably right, but there may be an age cutoff. But in someone this sick, if he doesn't qualify for a heart transplant or doesn't want a heart transplant, he may be someone where I would do the LVAD, left ventricular assist device, which is the right answer here. And really, they're either a bridge to transplant or a bridge meaning destination therapy. There is survival benefit in individuals who use it for destination therapy. And this patient has several markers that he might be a candidate for this, whether it be the multiple hospitalizations, worsening kidney function, low sodium, unable to tolerate other heart failure medications. And I put down here things I had to look up myself. In most centers, the cutoff is around 65 years of age, but if I don't know, or you don't know, always ask your hospital program if they have, transplant available. And you got to be cancer free for at least 5 years. And if I don't know that, I always just look it up. So, what are going to be my pearls for chronic heart failure management in this patient? In patients in general for your board exams, once again, current guidelines recommend replacing ACE and ARBs with, the valsartan sacubitril combination. Also, patient with heart failure, you want to start beta blockers, but just not in the acute setting. You don't tolerate this with acute decompensation. Definitely SGL2 inhibitors have great data for both patients with both preserved ejection fraction and reserved ejection fraction, whether you have diabetes or not. Aldosterone antagonists are often underutilized, so they're definitely, remember, they're a pillar when we talk about, goal-directed medical therapy. And ivabradine, we mentioned a lot about that today, is in individuals when you can't get the heart rate below 70 with beta blocker therapy. And having tachycardia is not beneficial, whether it's systolic or diastolic, meaning preserved or reduced ejection fraction. And always consider the 4-pillar regimen as the foundation for medical management for goal-directed medical therapy. And with that being said, let me see if I can go through stress testing, as quickly and not too rushed as possible. But I just want to say a few things, is that when we talk about stress testing, I'm already assuming you know when to initiate stress testing. Stress testing really comes in 2 types. Is it exercise or chemical? And I'll ask everyone, which one is always our default answer for the boards and clinical? exercise. Now, when we say about exercising, you need to know they could reach their heart rate max. And what is going to be their heart rate max, everyone? It's 220 minus the age, around 80% of that. At least that's what I check before I do some elliptical. And it's important to know if they can reach their heart rate max, because if they can't, then that exercise test is not valid. Then if that doesn't happen, they need a chemical stress test, and who knows in real life if the insurance is going to cover it. So of course, you want to make sure they reach their heart rate max. Exercise, everyone, does not necessarily mean that you need to jump on the treadmill. It could be a bicycle. It could be an ergometer of the hands and arms. So there are other things besides jumping on the treadmill. So of course, when you exercise, which is always our default, you got to know what to pair up the exercise with to see if there's going to be damage to the heart itself. So the three main things we pair up is going to be ECG, echo, and I'm going to use the broad word nuclear. So, of course, the question is, which one should you pick? Well, the default answer on the board exams is always going to be exercise ECG, exercise ECG. But when do you not use ECG, and I put it right here, anytime you have baseline abnormalities, then you can't use the baseline ECG. That should be pretty easy. And with that being said, I do want to mention something about some of the new recommendations for people with left bundle branch block and paced ventricular rhythm in a few minutes. And if it's not going to be ECG, you can pair it up with an echo. One of the limiting things is maybe their body habitus, not just to say elevated BMI, but people with, emphysema and obstructive airways disease. Maybe they have a small rib space where you can't get the probe in between the ribs. Maybe there's a lot of air in the chest, and air is always the enemy of ultrasound. And the last is a nuclear study. And of course, nuclear studies are very prognostic, but unfortunately very expensive and time consuming. So if they can't exercise, your default is always chemical. Then the question becomes, what chemicals are out there? And of course, I think I kind of clump three of them together. I kind of clump dipyridamole, adenosine, and regadenoson. Why is everything always such a tongue twister? Regadenoson all together. So these are mainly dilators. So when we think about, adenosine, dipyridamole, and regadenoson, all those are going to do a coronary steal syndrome, which steals blood flow away from the heart in, causing them to have that demand. And they work by not increasing the heart rate, such as things like dobutamine. One of the side effects when you think about adenosine and dipyridamole is that in patients who have, underlying lung disease like asthma and COPD, especially if they're actively wheezing, they can cause bronchospasm and cough. So you want to avoid that. When we came up with, brand name Lexiscan, which is regadenoson, we thought that would be the answer to some of the bronchospasm that was induced by things like adenosine and dipyridamole, but it still can cause it. Dobutamine works by increasing your heart rate. It's a beta-1 agonist, and it's very similar to exercise, because when you exercise, you're increasing your heart rate, and that's what dobutamine does. Of course, I want to avoid dobutamine in people with arrhythmias, but I really will talk a little more in detail about some of the new recommendations for people with left bundle branch block and paced ventricular rhythm. So once you decide what chemical you're going to use based upon side effect profile, then of course, what are you going to pair up with it? The core three are always going to be ECG, echo, and nuclear. I put up here things that you can combine with chemical, things like an MRI or things like a PET scan, but those aren't commonly used clinically or on your board exams. So my take-home message is that, cardiac stress test is an important diagnostic and prognostic tool in the evaluation and management of patients with known or suspected heart disease. And like I mentioned, you could do stress testing in a variety of ways. The most commonly used and widely available stress testing modalities are always exercise ECG, or default for the board exams, or doing an exercise or pharmacological stress combined with imaging, like a stress echo or a stress nuclear. So here's a picture of someone doing the classic Bruce protocol in a cartoon when they're running on a treadmill. This one's on the bicycle. And this is looking at the images when we do nuclear, looking at the resting images and looking at the stress images to see if there's take up in the myocardium. This is really what I want to talk about, is some of the new recommendations for left bundle branch block. Now, the 3 bullet points, I'm just going to read them out. It says, doing a nuclear stress or an echo stress, both have significantly higher diagnostic accuracy than ECG and should be used for patients with baseline left bundle branch block who requires a stress test. Both imaging, whether it's nuclear or echo, are appropriate, but you don't have to memorize that, because what did I say about ECG? Don't do an ECG when there's any baseline abnormalities. So I just wanted to pound that home point. So why not ECG? Second bullet says many studies have shown that when you do, an exercise-induced, when you do an ECG, you see exercise-induced ST segment depression, even though there's no ischemia. So that's one of the main reasons why you don't want to do the ECG. But here is the most important take-home message, everyone, for your boards, is the third bullet point, is that when you want to stress these patients, they recommend vasodilator stress rather than exercise or dobutamine. And what did I put in red here? This is true for patients who can even exercise. So very important that, and of course, the vasodilators of choice are the big three: dipyridamole, adenosine, and regadosone. And which one you use really depends on your own hospital setting, and they will not make you choose between these three on the board exams. Same thing if you have a paced ventricular rhythm. Most important is if you want to do a stress, pair it up with imaging such as an echo or nuclear. And once again, vasodilator stress is recommended over exercise and over dobutamine. So those are going to be very important pearls for your board exams. And I just want to go over a couple questions, and I'll let everyone go. So a 60-year-old man is evaluated for chest pain for 4 months duration. He describes pain as sharp, located in the left chest with no radiation or associated symptoms that occur when walking 1 to 2 blocks and resolves with rest. Occasionally, the pain improves with continued walking or occurs during the evening hours. He has hypertension. Family history does not include cardiovascular disease in any first-degree relatives. Is only met as a calcium channel blocker. On exam, he is febrile, normotensive, non-tachy, non-tachypnic, BMI is 28, no carotid bruise were present, normal S1 and S2, no murmurs are heard, lung fields are clear, and distal pulses are normal. So of course, what do you get first? ECG. And for time's sake, wow, this looks pretty normal. Remember, on your board exams, if you're scrutinizing this for more than a few seconds, I think that's the wrong way to approach it. They're really going to try to show you obvious findings when they throw out an ECG. This ECG is normal. So which of the following is the most appropriate diagnostic test to perform next? So let's work on this together. So can this person exercise? Yes or no? The answer is yes. So of course, I see stress, adenosine versus exercise. I'm always going to pick exercise. I think we all agree that going to get a coronary angiography is a little too aggressive, so B is wrong. Settling just for an echo is not going to give you enough information, so C is wrong. So I really came down to, am I going to do a chemical stress or an exercise stress? And the answer is he can exercise. He has a wonderful ECG. He's going to get an exercise treadmill stress test. The answer here is going to be what? D. So this is the classic go-to on the board exams right here. What about this 74-year-old woman is evaluated for a 3-week history of left shoulder pain and dyspnea on exertion. Medical history is significant for COPD, hypertension, CAD. She underwent stenting of the mid-LAD 3 years ago because of her lung disease. She has limited exercise ability. Important. Meds are ACE inhibitor, hydrochlorothiazide, statin, patient on aspirin, fluticasone, albuterol, and ipratropium, probably for her lung disease. On exam, she's a febrile, normotensive, non-tachy, non-tachypnic, BMI is 29. Her CVP is 8. Cardiac exam reveals a grade 2 out of 6 mid-systolic murmur, heard best over the cardiac bases. And there's this wheezing, late expiratory wheezing bilaterally. ECG shows LVH and repolarization abnormalities, so stuff on the ECG. Which of the following is the most appropriate diagnostic test to perform next? Well, when I'm looking at the choices here, what jumps out at me? I don't think we're going to go straight to the cath lab on this patient, so B seems to be the wrong answer. Or do I start off with stress test? Can the patient exercise? And the answer is no. She's limited based upon her lung disease, so I'm not going to pick D over here. So it really comes down to, is this patient going to get adenosine or dobutamine? And if she's actively wheezing, is this a good patient to give adenosine to? The answer is no. This will be dobutamine combined with some modality, and the best thing here from the choices is echo. So the answer is C. Outstanding. And I did mention already about some of the dilators, dipyridamole, adenosine, and regadisone. What is regadisone? It's an adenosine agonist, and we're hoping that it would, be more preferable to other stressors like adenosine, which are less selective. Hopefully, they would have less side effects. It really didn't pan out as much as we thought it would, but it is an adenosine receptor agonist, and I still would be careful in patients who are wheezing. And one of the last ones we're going to do is going to be this 50-year-old woman is evaluated for a 3-month history of progressive chest pain. The pain is worse with physical activity, radiates to the left arm, is associated with diaphoresis. The pain is revealed by rest. On exam, blood pressure is elevated at 169/90. The pulse rate is 58. Cardiac exam reveals an S4 and no murmurs. ECG shows sinus rhythm and left ventricular hypertrophy with a strained pattern, so baseline ECG abnormalities. Which of the following is the most appropriate diagnostic test to perform next? Well, it always comes down to, can the patient exercise or not? And can they use an ECG? So right off the bat, because of all the baseline abnormalities here, I'm definitely not going to do a ECG over this. Then I think about, am I going to make the patient do a dobutamine echo? Would it be a dobutamine myocardial perfusion imaging? Or are we going to do an exercise myocardial perfusion scan? And when I look at this patient, you got to be careful because she is having pain on exertion, but there's nothing here that says the patient can't exercise, but I'd definitely be very careful about that. And with this, I think that exercise imaging would be the best answer for this patient. I would pick D. And the last thing I wanted to go over, I know I went over and I apologize, everyone. I hope I didn't offend anyone by going over. I just want to do one last question, and I promise we'll do our summary. So this is a 71-year-old, and if I don't say it already, thank you for everyone staying on. All 28 of you, you're all amazing. So is evaluated for a 6-month history of exertional chest pain. The pain has increased in frequency and now occurs earlier during his exercise regimen. Oh boy. The pain is relieved by sublingual nitro. He underwent coronary artery bypass grafting 4 years ago. History is also significant for hypertension and hyperlipidemia. He's on the beta blocker, ACE inhibitor, statin, and aspirin. Physical exam findings, including vital signs, are normal. They do an ECG that shows in bolded red left bundle branch block. So which of the following is the most appropriate test? So they want to see if he's still having, heart disease in regards to ischemia and infarction. He wants a stress test. So with the left bundle branch block, what were the guidelines? Is that even if the patient could exercise, we don't want the patient to exercise. What mimics exercise is always going to be giving things like dobutamine, which crank up the heart rate. So anytime I see the word dobutamine, like dobutamine echo, I'm not going to use dobutamine. That's choice A. Exercise ECG, double whammy. He shouldn't exercise to begin with, and I wouldn't use an ECG because of the left bundle branch block. Exercise with nuclear. I love the nuclear, but I won't have him exercise, so C is wrong. Now this looks good, a vasodilator, and of course that's how they're going to ask you this on the board exams. They're not giving you one specific one like adenosine or dipyridamole. They're giving a vasodilator combined with what? Nuclear. And that's what you need to do when you think about left bundle branch block. So D is the right answer here. So what's going to be my pearls for everyone? Remember, because of the inability to adequately detect ischemia, ECG changes in the setting of a baseline left bundle branch block or paced ventricular rhythm, exercise ECG alone is non-diagnostic for coronary artery disease. Stress, nuclear, or stress echo both have significantly higher diagnostic accuracy than an ECG and should be used for patients with left bundle branch block or paced ventricular rhythm, require stress. And the third bullet, vasodilators are preferred over dobutamine and bolded red, exercise in patients with LBB or paced ventricular rhythm. This is mainly secondary to the high rate of false positives in the absence of coronary artery disease. And with all that being said, I promised I'll be done, in 1 hour. I know I went over. I really hope you enjoyed this. These are going to be high yield pearls for the board exam. And hopefully one day I could see you in person. And thank you for staying on all night and listening. Good luck. And here's my contact info. So we have two in the Q&A for ICD and CRT. What are the criteria for thinking of placing these in heart failure patients? Does it matter if the cardiomyopathy is secondary to outside of ischemia in terms of timing and EF? Great questions on so many levels. You know what I mean? So yes, if someone got admitted to the hospital, and let me just say this first, that when it comes down to primary and secondary prevention with ICDs or CRTs, it doesn't matter if it's going to be ischemic or non-ischemic cardiomyopathy. When someone does have like a heart attack, a acute coronary syndrome, and when they get discharged from the hospital, of course, what do we want to start first is goal-directed medical therapy. We want to see what kind of cardiac remodeling happens, and we'll see if it improves the EF. So someone where their EF is low at the time of discharge, from acute coronary event, no, I would not put an ICD or CRT right away. I would reevaluate them, after I do goal-directed medical therapy. And that's where there could be a role for doing something like a life vest, which is the wearable defibrillator in that buffer period where they get discharged from the hospital. They're on goal-directed medical therapy to see if the EF recovers, meaning goes higher than 35%. So remember, whether it's going to be ICD or CRT, both of those, the EF has to be less than 35%. So, wonderful. And when we talk about criteria, I said it already. ICD is going to be primary, secondary prevention when it's going to be the EF is less than 35%. It's going to be for New York heart failure, class 3 and class 2. We tend to avoid those in class 4 because, they're really going down a different route, maybe towards the hospice care. CRT, everyone, is to make you feel better. And when do we think about these? People who have a wide QRS complex. I mentioned in the questions today that their QRS width was 150 milliseconds. You want to think about them who also has a ejection fraction less than 35% predicted. And if they qualify for these are not going to be individuals who are going to be shocking the heart. We're going to try to resynchronize the heart. So we have used these in individuals who have New York heart failure, even class 2, 3, and 4 sometimes, because it's not shocking the heart. You're just trying to make him feel better. But that's a great question. And that actually talks exactly what we're talking about with the question below it. So this is wonderful. And let me go to the chat. Where are the chat questions? I see a lot of wonderful things. I see a lot of thank yous, which made me very happy. Thank you, everyone. Oh my God, I really appreciate those. And if someone is on a calcium channel blocker and beta blocker, but blood pressure stable, but developing symptoms, would you add 4 pillars or definitely DC the CCB? It all depends. When we talk about calcium channel blockers, for everyone, there are 2 main types. Dihydropyridines, these are things like amlodipine and nifedipine that work more in arterioles that for blood pressure control. Then, of course, there are the non-dihydros, things like verapamil and diltiazem that you could use for heart rate. So it really depends on what setting. So, in acute coronary syndrome, something opposite of this, if you really need to control the heart rate, you can't use a beta blocker. Non-dihydropyridines are like, quote unquote, second line. If someone has, in a high blood pressure that's hard to control, yes, you could use CCBs to control their heart rate. Their blood pressure. But do we use them directly for heart failure in itself? The answer is we try to avoid doing that. But, I would say that I probably, the question you're specifically asking me is that, if someone the blood pressure is stable, you know what I mean? And they're already on the 4 pillars, which is really focusing on the heart failure issues. It really depends on what we're doing for their blood pressure. Are they on 4 pillars? They're still are poorly controlled hypertensive. Then we would think about the risks and benefits. But I wouldn't add a calcium channel blocker, dihydro or non-dihydro, unless there are other indications to add. I wouldn't add it directly just for the heart failure. And I love the great talk. I love all these things. And I just want to say thank you. And everyone pretty much stayed on. So everyone's so amazing.